Move on to the next session titled Hernia, Basics and Beyond in Herniology. Once again, timing 8 plus 2 minutes. May I invite to chair this session Dr. C.J. Verghese, Dr. Joe Stanley, and Dr. Muhammad Ismail. The speakers, Dr. Vinayak Rangan, Dr. S. Sri Kumar, Dr. Sandeep Abraham Verghese, and Dr. Srinivas, please. Dr. I.C. Srinivas. May I request the speakers also to kindly join the chairpersons on the dais. Also to co-chair this session, Dr. Ajay Kumar and Dr. Jayant Stephen, please. First speaker, Dr. Vinayak Rangan. Over to the chairpersons.
Actually, the next session is hernia, basics and beyond in herniology, and the first talk is by Dr. Vinayak S. Rangan.
Yes, sir, Bipin. Dr. Vinayak Rangan, he's basically a surgeon. Actually, he is very much interested in the AI, artificial intelligence, in the abdominal wall CT imaging. He has presented in the European Hernia Society, American Hernia Society and all. So, thank you for accepting our invitation.
Thank you so much, sir. Thank you, Dr. Vipin. It's a great honor because even though I'm not from Kerala originally, I was born in Kerala, and it gave me a lot of pleasure to attend the Professor Raghavachari oration because like him, I did my undergraduation at Kilpauk Medical College and my general surgery at Madras Medical College. So it feels great. It feels like home right now. Thank you so much. So my presentation is going to be slightly unconventional, and I'm going to take you through why you would want to do a CT scan in a hernia, patient with a ventral hernia. And also, a significant part of my presentation is how you could use deep learning, computer vision, and artificial intelligence to augment the entire experience. So who do you think is there in the screen? Any F1 fans over here? So yeah, so that's going to be the question. So this is a very famous F1 driver. At the end of the presentation, whoever tells me the answer is going to get a prize. And at the end of the day, we surgeons do have an ego, a big one to say the least. And we consider ourselves as the drivers of any particular event. We are the F1 drivers. But behind us, there is a big engine which is necessary to propel us. And of course, there is a team which often goes unrecognized when we do some sort of good works. Behind every esophagectomy, behind every great complex APR, there is a big team and there's a big engine. So the question is, what propels the engine? Is surgery an art or is it a science? Or is it both? Surgery has been considered as an art by many, but now we are straddling into areas of unknown territory where surgery is now considered more as a science. So what you see over here is an image of a surgeon drawn in the style of Picasso, but unfortunately it has not been drawn by an artist but has been generated by an generative AI algorithm, DALL-E. So to convert surgery into a more objective branch where we can measure outcomes, where we can predict outcomes, we need data. But the real challenge is, where is all this data? And that data is available in plenty in our Indian medical colleges, in our Indian government hospital scenario. But how do we work with the data? How do we process this data? There is an immense amount of data in this room. If I look at this audience, I can find out what kind of shirts do surgeons like to wear. Do they like to wear solid colors? Do they like to give checks? Do they like to wear half shirts, full shirts? And that is data which a clothing manufacturer can actually influence and can project ads onto a surgeon. So the real challenge lies in how do we process data and how do we work with it. I'm Dr. Vinayak Rangan. I'm the founder of a startup called Curium.life. We are an exclusive surgery startup. We work on making surgery safer through artificial intelligence. I'm also working in the Department of Pediatric Surgery as a senior resident. I also teach deep learning in endoscopy and surgery at IIT Madras. So today's topic is going to be about imaging in hernia surgery and how we can use artificial intelligence to augment it. Why do we need CT scans in hernias? If you look at this particular CT scan, there's a lot of information you can see. There is a defect, There is a sac, there are contents in the sac, it could be bowel, it could be omentum. So there are objective measurements and there are subjective measurements. Objective measurements are the defect dimensions, the defect location, the muscle width and thickness, because that is going to determine what kind of repair you're going to do. The hernia contents and the volume ratios. The volume ratios, when I mean the Tanaka index and the Sabag ratio. Then there are subjective measurements. We can talk about denervation. Is there a significant amount of denervation in the CT scan? Now, how do you determine that? You can see how the muscles are oriented. You can see how much of there is disparity in the symmetry of the muscles. Old meshes. We did a pilot study and we found that 9 out of 10 radiologists could not identify a mesh, sometimes even a simple mesh in a CT scan. Additions are again a very subjective phenomenon, because some surgeons might say this is an addition, some radiologists may say this is not an addition. And then how do you determine complexity? An experienced surgeon, a person who does AWR daily for a living, can look at a CT scan and say, this is a complex hernia. No, I don't want to do this. But then you might ask him, how do you know it is complex? What makes you say it is complex? No, I know it is complex. That's because the surgeon has spent enough time reading CT scans. But how do you define that? How do you bring objectivity into that? So the question is, should we help the radiologists by solving their problems? And when I say should we help the radiologists, most surgeons say no, let them do their job. But the fact is you're helping the patient, not just the radiologist, by getting some information. So, what do you think this is? Audience, please. It's an apple, right? Yeah. What do you think this is? Louder, please. Yeah, it's a green apple. This? Yellow apple. This one? Eaten apple? Yeah. This one? A rotten apple. This one? Slightly more rotten. What was taught to you in your school? I have a 5-year-old son, and in his school they teach him that an apple is a red fruit and it has a specific shape. But the moment you saw this, you said this is an apple, this is an apple, this is an apple. The fact was that despite not being taught, you had formed neural circuits in your brain which say that this is an apple, even though it is very different from what you have been taught. There must be somebody over there who cannot see me, but still he will be able to determine that this is a male who is talking. How does he know that? Because since childhood you have been exposed to male voice, female voice, all the disparities. Nobody teaches you what is a baritone, what is the frequency at which a male talks or a female speaks. So all these is neural circuits. Giving you a better example. Who is this? George Clooney? All of you agree? How many of you agree? A show of hands. Who is this? DiCaprio? Great. Who is this? Danny DeVito. Okay. Who is this? Yeah, Robert De Niro. Who is this? How many of you know him? Don't answer. How many of you know him? Suddenly I see less hands being raised. 2 minutes. And who is this? Oh yeah, I got the answer. But the fact was that, what do you think these two people do? How many of you, what profession do you think they are? Louder, louder. Actors. So the fact is that you saw all these images and corresponded, you had formed enough neural circuits in your brain to determine that these were actors. By the way, who is this? Marlon Brando, who played Don Corleone, and this is John Wayne. So, this is how a neural network looks like. There's an input layer and there's an output layer. A complex neural network is with which we work, and we form complex imageries, we analyze complex images, and we solve problems in surgery and radiology. So we're just inserting a DICOM file. We label thousands and thousands of CT scans, sacs, and the defect. And we feed this into our algorithm, which we have made in our lab. And we are able to segment the muscle. We are able to identify the defect. So I'm going to show you some magic over here. The image on the left is what has been done by the radiologist. And the image on the right is what our computer has predicted. We have been able to identify the sac using deep learning. Same thing. So due to lack of time, I'm just going to rush, but I'm going to show you something else too. So this is where we have identified a mesh on a CT scan. Now this is something which radiologists have found it very difficult. We have been able to identify, the image on the right is the model prediction and the image on the left is the true label, the ground truth, which has been done by the radiologist, and we have achieved more than 90% accuracy in mesh identification. We have done also a bit of work on sarcopenia, which is a major risk factor in pancreas, stomach, lung, most malignancies. We have automatically calculated the L3 level and an index called the HUAC. As you can see, the psoas muscle has been segmented automatically by the computer in our image. So using this, we hope to create a hernia decision support system, which allows us to predict what would be the risk of ventilatory failure, what would be the risk of infection, what would be the need for component separation. If the need for component separation is higher, you can refer your case to somebody who can do an AWR, who can do a TAR. Last, this is something I would want to talk about maybe at the next Kasicon. This is our intraoperative model, which we plan to show a demo within the next 60 days. We have been able to segment the gallbladder in intraoperative anatomy. You can see the cystic duct, the instrument, the fibrofatty tissue, and the cystic artery. So our aim is to objectively score the CVS. So if somebody says, I have got a CVS score of 5 out of 6 or 6 out of 6, now I think within the next few months, we will be confidently able to give him a score of 4.5. No, you still need to detect the, remove a little bit of fibrofatty tissue before you can say you got a score of 5 or 6. So just finishing off with a quote from Henry Ford. If I asked people what they wanted, they would have said faster horses. But he went on to invent cars. The ultimate aim, obviously, is to save lives and make surgery safer. Thank you so much.
Thank you, Dr. Vinayak. It's an interesting presentation. Any questions? Thank you. We will move to the next.
Thank you, sir.